So we'll start with immunosuppression in transplant. Now, whenever a organ is transplanted, this organ acts as a graft is an potential antigen in a host. To transplant a kidney or transplant a liver or a small bowel transplant is done. So that graft is a potential antigen to this host. That host has never had an experience of that antigen in its entire life. So because this is a fresh antigen, this host mounts an immune response against this antigen. Now, this is a fresh antigen that is introduced into the body. And also, there is a risk of ischemia reperfusion injury once it is grafted. So, because of these reasons, in the initial phases, when the graft is put into the body, there is a heightened sense of inflammation, and the inflammatory response to this graft is very aggressive and it can go to the rejection. So, if you want to prevent this rejection, we need to use the drugs which are very aggressive. So, in the initial phases, we use drugs which are very aggressive and they inhibit this immune response against the graft and prevent its rejection. So, those drugs which are used are called as induction agents, and this is called as induction phase. So, the first phase of immunosuppression in a transplant would be induction phase. And later, when this aggression of the immune system against the graft reduces, we taper down these drugs and we start maintenance phase. Right? So immunosuppression happens in two phases, a more aggressive induction phase and a tapered maintenance phase. But if for some reason the rejection has already happened and you want to reverse this rejection, then you give certain drugs which are called as rescue agents. So rescue agents are the drugs which reverse the rejection that is already under its way. And most of the time, the drugs which are used for induction also work as rescue agents because they're more aggressive. So when you plan to give these drugs, there are various ways where you can suppress this immune system. Right? So this host has mounted a immune response against the graft that has been transplanted. Now it can involve the T cells, the B cells, the monocytes, macrophages, neutrophils, or pro-inflammatory cytokines. So, and there are antibodies. So it can use any of the immune system cells that are available and mount a immune response against this graft. But most of them ultimately terminate in activation of complement. Right. So whatever pathway is utilized, it ultimately terminates in the complement system. Activation of complement will produce membrane attack complex, and this will attack the graft. Right? So now, if you want to suppress this, we can develop the drugs which will target any of this system, and therefore there are a wide variety of drugs which are available. Now, initially, what they did is, if they want to target this T cell, they took this T cell and they inoculated it into a other species, for example, a rodent or a horse or a rabbit. Now, if this T cell is inoculated into a rat or a horse, this T cell acts as a foreign antigen in this rat or horse. Now, that will elicit the immune response against this T cell. And there are various types of cells, they will produce their antibodies. Right? So, a cell type A cell produces its antibody, a type B cell produces its antibody. So, various antibodies from various cells are produced. But all these antibodies will act onto that antigen or T cell and it will cause a destruction of this T cell. Now, if you are able to isolate the serum, collect the serum, and purify these antibodies, you have a set of antibodies now available, which you can inject into the human being and cause the destruction of this T cell. It is simple. So you take a T cell, you inoculate it into a rat or a horse. In response to that, they produce antibodies. You collect these antibodies, purify them, and you give it into the human being so that it will act on this T cell and it destroys a T cell. So the problem with this is whatever antibodies we get, they are not from a single cell, but they are from different cells. They produce this antibody. This antibody, all these antibodies which are derived from different cells act on the same antigen, but they have different binding sites on antigen. So these binding sites are called as epitopes. So if this is a antigen, now all these multiple antibodies that are produced from multiple sources, act on this same antigen, but one binds here, one binds here, one binds to this, one binds to this. So there are different epitopes for this same antigen. So that's why these are called as polyclonal antibodies. So polyclonal antibodies are those antibodies which are derived from different types of cells and they act onto the different epitopes of a same antigen. So that is why they are non-specific. Now, because they are non-specific, they also have side effects which are non-specific. That's why they have a lot of side effects which are not desirable. Now, that is why they wanted to develop an antibody which acts only on a specific epitope and they are derived from a single clone of cell. So they are derived from a single type cell. These antibodies are derived, these antibodies are taken, and when they given it to the human being, they act onto a single site, a specific site onto the antigen. They are called as monoclonal antibodies. So these monoclonal antibodies end with the suffix "mab", so which means a monoclonal antibody. Now, if this monoclonal antibody is completely taken from a mouse source, from a rodent source, it ends with the suffix "omab", right? If it is taken from a human, it is completely a human source, then it ends with "umab". This is a nomenclature. So once you see that there is "omab", it means that it is taken completely from the mouse. You see that it is "umab", it is taken completely from the human. But sometimes what happens is you need to mix a human protein with a non-human source protein. So that is called as humanized. So where about 10% will be non-human protein, which can be a mouse or any rodent or rabbit or a horse protein can be there. So it is a 10% is non-human source. So if it is non-human source, it ends with Zuma. Right? But if you increase this 10% non-human source to around 25 to 30 nucleotides, which are from non-human source, it is called as chimera. Right? So chimeric antibodies are those where the non-human source protein is around 25 to 30 nucleotides, which is more than that of a humanized antibody. So if it is chimeric, it ends with Zima. So if it is humanized, it ends with Zuma. If it is chimeric, it ends with Zima. Now, sometimes what happens is you want to produce a humanized antibody where the non-human source protein is only 10%. But in the process of production of this humanized antibody, you need to produce a chimeric intermediate, right? You start the process with an aim to produce humanized antibody ultimately, but to produce this, you need to add more nucleotides and then you delete these nucleotides. So you first produce a chimera and then you humanize this chimera. So that is why it is called as humanized chimera, where there's a chimeric intermediate that is produced before this humanized antibody is produced, right? So if it is humanized chimera, there is a prefix Z-ZU-ma, right? Because it is humanized chimera, there's a prefix Z-ZU-ma. So these are the different types of the monoclonal antibody that are produced. And if you remember this, it will be helpful. So for example, if I tell rituximab, so it means that it has Zima, it is a monoclonal antibody, which is a chimera. So if I tell daclizumab, so it is a monoclonal antibody, but if because zoo is there, it is humanized monoclonal antibody. If I tell darutumumab, because it is umab, so it is a human monoclonal, completely human monoclonal antibody. If I tell otelixizumab, because it has otelixi, C zoo, it means it is a humanized chimera. So with this background, we'll first start with induction agents. So these are the agents which are more aggressive. So they are used as induction agents. But remember, because they are more aggressive, their side effect profile is also more aggressive. They cause more immunosuppression, so more risk for secondary malignancies and more risk for infections. So the first of this induction agent would be a anti-thymocyte globulin. It is an anti-thymocyte globulin. Now, what happens here is you take human thymocyte, which basically comprises of T cells, lymphocytes. So you take human thymocyte and you inject them into a rat or a horse. Now, because this is foreign to this rat or a horse, they produce antibodies against this. Now, these antibodies, as I told you, are polyclonal antibodies because they are from different sources and they act on different epitopes of the same antigen. Now, these antibodies are the serum of this is taken and it is purified so that you get gamma globulins, which are nothing but antibodies. Now, this is taken and injected into the human, which will cause a destruction of T cell. So, antithymocyte globulin or a globin is a set of polyclonal antibodies which are collected from the serum of the rat or horse, which are immunized with, which are inoculated with human T cells. So these are formed against the human T cells. Now, if it is from the rat, it is called as rat antithymocyte globulin. If it is from the horse, it is called as horse antithymocyte globulin. The rat is more effective and has got lesser side effect profile compared to that of a horse. So that is why rat is more commonly used. Rat ATG is more commonly used than the horse ATG. Now, what happens when you inject ATG into host? So you inject ATG into host. Now, because this ATG is produced against T lymphocyte, it will act onto the T cell and it causes the lysis of T cell. So whenever there is a graft in the body, this graft will activate the immune response. And this immune response will make the interleukin 2, which is a powerful cytokine, act on the T cell. And this T cell mounts the immune response against the graft. Now, what we do is we destroy this T cell. Because we destroy the T cell, we downregulate the immune system. So that is why they are used as induction agents. And also they can be used as rescue agents. But the problem is when they cause the lysis of this T cell. Now this T cell, when it is lysed, it will release cytokines. When cytokine is released, this will elicit the inflammatory response and the patient has fever with chills. Right? So this is called as cytokine release syndrome. Because of the death of the T cells, there is release of cytokine that produces fever and chills in the patient, which is called cytokine release syndrome. But this is seen in about 20% of the patients, which is self-limiting. Just giving antipyretics and antihistamine will help. This is not a major side effect, but a common side effect. Now, what are the other side effects? So, side effects of antithymocyte globulin. First is, as I told you, most common in 20% of patients, a cytokine release syndrome is seen, which is self-limiting. You may need to give maximum antipyretics and antihistamine. But the major side effect is, as I told you, because it is polyclonal, it is not specific. It reduces the platelets and produces thrombocytopenia. It also causes anemia. And because it reduces T cells count, the patient is prone for increased viral infections like herpes simplex virus, varicella zoster virus, cytomegalovirus, and Epstein-Barr virus. Because the patient is prone for Epstein-Barr virus, the patient also has risk of secondary malignancy, which is Epstein-Barr virus lymphoma. Right? So these are all the side effect profiles of the ATG. Now, to take out all the side effects of the polyclonal antibodies because of their non-specific nature, they wanted to produce a monoclonal antibody. And this was from a murine source. That is why they called it as muromona. Now, this was the first monoclonal antibody that was used for transplant. So, its nomenclature is that is why a little different. So, they called it as monoclonal antibodies. So, monomonav, and it was from the murine source, muromonav. Now, what this muromonav does is once you give muromonav to this, as I told you, there is a T cell. Now, this T cell has a receptor which is called as CD3. So it is a cell surface marker of a T cell. Now this CD3 receptor has many chains, out of which one chain is a epsilon chain. Because this is a monoclonal antibody, when you give muromonov, this will come and act on this epsilon chain. Now all these are cell surface receptor. It means for them to receive signals, they need to be present on the cell surface. But once muromonab comes and binds to this CD3, epsilon chain of the CD3, it causes internalization of this receptor. So this binding makes the receptor to internalize into the cell. So once there is an internalization, even if there is a signal, this cannot be sensed by the T cell and the T cell will not get activated. So it inhibits T cell activation by internalizing the receptor. But also what it does is, because it comes and binds, it coats the T cell with opsonization and it induces phagocytosis of this T cell. Right? One thing is it will inhibit the activation of T cell. Second is it causes the destruction of the T cell by coating the T cell as an opsonin, and it causes the other phagocytes to phagocytosize this T cell. So when there is phagocytosis, the T cell lysis happens and that releases cytokines. Now the cytokine release with this is so high that it can lead to pulmonary edema, it can lead to hypotension, and it can lead to myocardial depression. And it is so dramatic. These effects are so dramatic that initially, when they used muromonab, they needed to give steroid as a pre-medication. So they first give a steroid, and which was followed by giving muromonab because such was the magnitude of release of these cytokines. So this was one problem associated with this, where there was a massive cytokine release syndrome. The second is because this itself is taken from a murine source, and this will become a foreign antigen to the human body, and the antibodies are produced against this antibody only. So they are called as HAMA, human anti-murine antibody. So these antibodies will act against this muromonab and they cause destruction of muromonab and they reduce its efficacy. So these are the two problems that were associated with muromonab, where human anti-murine antibodies are produced, which reduce its efficacy, and massive cytokine release syndrome. So this was also called as OKT3, and that is why it was withdrawn from the market, and now it is only of a historical importance. Now there are certain drugs which act in a similar fashion to that of this OKT3. Now these drugs can be humanized or they can be humanized chimera. So humanized drugs are teplizumab. Zumab is humanized, and vicilizumab. So these are the drugs which have similar action as that of OKT3 or muromonab. And humanized chimera is otelixizumab. So cizumab, it is a humanized chimera. So these are the drugs which are in similar action that of OKT3. They are not yet introduced into the standard regimens, but they can be considered. Next is whenever there is an antigen in the body. Now this antigen has to be presented to the T cell. So a foreign antigen enters into the body. Now this antigen has to be presented to the T cell by antigen presenting cell. So there are cells in the body, the endothelial cells, dendritic cells, monocytes, macrophages, which can act as antigen presenting cells, and they present this antigen to the T cell. When they present this antigen to the T cell, the interleukin 2 is released, which will act onto this T cell, and it causes clonal proliferation of this T cell, which is also called as clonal expansion. So the T cells have to undergo mitosis and they need to multiply and clonal expansion, and they get activated. So they produce a lot of other T cells, and all these T cells, when activated together, they mount a immune response against this antigen. This is what happens. For this interleukin to bind to this T cell, it needs a receptor that is called as interleukin 2 receptor. Right? So this interleukin will come and bind to a receptor which is present on the T cell. This receptor is called as interleukin 2 receptor. Now this interleukin 2 receptor has three chains, a gamma chain, a beta chain, and an alpha chain. Out of all the three chains, it is the alpha chain which has most affinity to the interleukin 2. And this is very much important for the action of the interleukin 2 in the initial phases. So this interleukin 2 comes to binds to all of this, but binding to alpha is very important. So once it binds to this cell surface receptor, So whatever binds to, whenever the ligand comes and binds to the cell surface receptor, it transmits its information to the cell surface receptor. Now, it is the duty of the cell surface receptor to transmit that information into the nucleus. So that information to the nucleus is transmitted by something called as intracellular signal transduction pathways. And one of the most important component of this intracellular signal transduction pathway is the mTOR, complex 1. We'll come to this later, but just remember as of now that one of the important signal transduction pathways, mTOR, complex 1, which will transmit it to the nucleus. And now this nucleus senses that the T cell needs to undergo clonal proliferation and activation. This is what happens. Now, what we can do is, there is an interleukin 2. This acts onto the interleukin 2 receptor on the T cell, which has alpha, beta, and gamma chain. Now, once this interleukin 2 comes and acts over this will activate the signal transduction pathways, and that will activate T cell. Activation happens. Now, if we can produce an antibody which comes and acts on this alpha chain and it inhibits the T cell activation, then we can prevent the immune response against the host. So that antibody which acts onto the alpha chain and inhibits this T cell activation was produced, and it was a monoclonal antibody. Now, it was initially a humanized form which was called as daclizumab. And later they produce a chimeric form of this, which is called as basiliximab. And because they inhibit interleukin 2 receptor, they are called as anti-interleukin 2 receptor antibody. Okay? So these are another class of the induction agents. Anti-interleukin 2 receptor antibodies, a humanized form is daclizumab, and a chimeric form is basiliximab. Now, daclizumab is not used, only basiliximab is used of this class, which will bind to the alpha receptor, and it inhibits the T cell activation. So that is why they can be used as a induction agent, and they can be used as a rescue agent. But what happens is, this T cell is dependent upon this alpha receptor only in the initial phases. As the inflammation phase goes on, now T cell can get activated even without the need for alpha receptor. So that is why these cannot be used in a maintenance phase. They are only in the initial phase. They cannot be used in a maintenance phase, because in maintenance phase, T cell does not depend much upon the alpha receptor to get activated and clonally proliferate. Now, if you see this, compare this with ATG and anti-interleukin 2 receptor antibody. Now, what ATG does is, ATG is a polyclonal antibody, and this is a monoclonal antibody. Now, ATG, what it does is, it causes destruction of T cell. Anti-interleukin antibody will not cause destruction, it just inhibits proliferation. Okay? So that is why this is associated with cytokine release syndrome, and virtually there is no cytokine release syndrome here. So this does not have a cytokine release syndrome because there is no destruction of T cells, only the proliferation is halted. And this is less potent compared to that of ATG. Because it is less potent, the risk of infections is lesser, infectious complications is lesser, and lesser secondary malignancies. And then there was a drug called as alemtuzumab. Now this alemtuzumab inhibits CD52, which is expressed on a mature T cell, B cell, and even on monocyte. So alemtuzumab was a drug which inhibits CD52, which is expressed on mature T cell, B cell, and monocyte. So that is why it was initially used in the treatment of lymphomas. Now, studies show that this alemtuzumab can be combined with the calcineurin inhibitor. So these are all the induction agents that are available. So to summarize the induction agents, what we have is a ATG, OKT3, which is muromonab, then anti-interleukin 2 receptor antibody and alemtuzumab. So ATG is a polyclonal antibody. All these are monoclonal antibodies. Now, ATG causes destruction of T cells. OKT3 acts onto the CD3 receptor, causes internalization so that it inhibits T cell activation, but also causes destruction of T cell. Anti-interleukin antibodies, these will inhibit the T cell activation. Now, alemtuzumab is a inhibitor of CD52, which is expressed on T cells, B cells, and even on monocytes. So these are all the induction agents that are available. Now coming to the maintenance phase. So once you come to the maintenance phase, you can use the drugs which are less aggressive, less potent. So the first drug here would be a corticosteroid. Now this corticosteroid can be given as a oral drug, which is prednisone, or it can be given as IV form, which is methylprednisolone. So once you give a steroid, this steroid will enter into the cell. And in this cell, this steroid will bind to a steroid receptor. It does not need a cell surface receptor. It can directly enter into the cell because it is a steroid, and it will bind to the steroid receptor in the cytoplasm of the cell. And once this binds, now this will enter into the nucleus. And in the nucleus, this acts as a transcription factor. And this transcription factor increases the transcription of I kappa beta. Right? So this is what a steroid does. So once you give a steroid, it will enter into the cell, inflammatory cells. It binds to the steroid receptor. This steroid and steroid receptor complex enters into the nucleus, where it acts as a transcription factor, and it increases the transcription of a gene that encodes for I kappa beta, so that a protein called as I kappa beta is produced. Now, what this I kappa beta does is, this I kappa beta will inhibit the nuclear factor kappa beta. Nuclear factor kappa beta is a very important protein in the production of interleukin 2. So because this inhibits the nuclear factor kappa beta, a steroid inhibits interleukin 2. So because interleukin 2 is inhibited, T cells are not activated. So it inhibits, a steroid inhibits T cell activation by inhibiting interleukin 2. It also inhibits the leukocyte response to an antigen, right? There's a foreign antigen is present, and this will inhibit the leukocyte response to this antigen, and it inhibits other inflammatory cytokines like tumor necrosis factor alpha and interleukin 1. Now, these are responsible for the production of the fever. So that is why a steroid reduces this fever. So they also inhibit tumor necrosis factor alpha and interleukin 1. They also inhibit phospholipase A2. Because phospholipase A2 is inhibited, all the arachidonic acid pathway and the products of this arachidonic acid pathway are inhibited. Leukotrienes and prostaglandins, all of them are inhibited. It also inhibits vasodilation. Right? It has multiple actions where it inhibits interleukin 2 production, inhibits T cell activation, inhibits leukocyte response to antigen, inhibits TNF alpha and interleukin 1, inhibits phospholipase A2, and it inhibits vasodilation. So that is why it is called as a global reduction in inflammation. Right? To multiple pathways, it reduces. It is called as global reduction in inflammation. When it comes to uses of this steroid, it is used mainly as a maintenance agent. But if you give a high dose steroid, now this high dose steroid can also act as a inducing agent or even a rescue agent, right? Because it blocks the production of interleukin 2. So it can be used as a rescue agent, and it can also be used as a reducing agent. But the problem with steroid is this can lead to a lot of side effects, especially it is diabetogenic. It can increase the blood pressure. It can lead to osteoporosis. And more importantly, it delays wound healing, and there are infectious complications. So because of these reasons, what we use is we use a low dose steroid. So to minimize the dose of steroid, we add other drugs. Right? So other drugs like calcineurin inhibitors or anti-proliferative agents are added so that the dose of steroid can be reduced, and that is called as steroid minimization protocol, where you add other drugs, multi-drug regimen is given so that the amount of the steroid that is used can be reduced. So this is called as steroid minimization protocol. So till now, if you observe, whatever drugs that we have discussed are, so either they are inhibiting the interleukin 2, they are halting the production of interleukin 2, or when this interleukin 2 once is produced, it acts onto the receptor. So they are inhibiting the interleukin receptor if the interleukin 2 is already produced. Now, this acts on the interleukin 2 receptor, and this receptor has already sent a signal to the T cell that it has to divide. Right? There is an antigen in the body, it is recognized by the immune system. Interleukin 2 is already produced, and it has been successful in sending its signal to the T cell. The intracellular signal transduction pathway are also successful, and the signal is sent to the nucleus, and it has started to undergo mitosis. Now you need to stop this cell at this stage, right? You need to produce an arrest in the cell cycle so that you prevent its proliferation. And those drugs that are used that prevent the proliferation of these T cells are called as anti-proliferative agents. These anti-proliferative agents arrest the rapidly dividing cells in their cell cycle. And two of those anti-proliferative agents are azathioprine and mycophenolate mofetil. First, we'll see about azathioprine. Now, this azathioprine, when given into the patient, the liver will convert this azathioprine into several active metabolites, two of which are 6-mercaptopurine and 6-thioinosine monophosphate. Right? So it gets converted into 6-mercaptopurine and 6-thioinosine monophosphate. So these are purines. So that is why azathioprine is a purine analog. Now, once these are produced, they will enter into the nucleus and they inhibit the alkylating stage in the DNA synthesis, and thereby they inhibit DNA synthesis. If at all DNA synthesis happens, during this production of DNA, obviously there will be some errors, and these errors are corrected by the DNA repair mechanisms. These will inhibit the DNA repair mechanisms also. And additionally, what they do is this thioinosine monophosphate should be converted to guanosine monophosphate and adenosine monophosphate, which eventually leads to the production of the adenosine. Now, adenosine is the source of energy for these cells. So what these do is they inhibit this conversion of thioinosine monophosphate into GMP or AMP, effectively decreasing the levels of adenosine so that cell is deprived of energy. And thereby they arrest the cell cycle progression. So that's what azathioprine does. It's a purine analog. In the liver, it gets metabolized into 6-mercaptopurine and 6-thioinosine monophosphate, which enter the nucleus. They inhibit the DNA synthesis, they inhibit the DNA repair mechanisms, and they deprive the cell of its energy. But the problem with this azathioprine is because it is inhibiting the DNA synthesis, it acts on all the rapidly dividing cells. There is one advantage to it because it is acting on all the rapidly dividing cells. It can be used as a immunosuppressive agent, or it can be used in autoimmune conditions like autoimmune hepatitis. But the problem is because it acts on all the rapidly dividing cells, it can act on gut mucosa also. It can act on liver also. It can act on bone marrow also and cause the destruction of these cells and cause the prevention from proliferation, right? These are the cells which need to be proliferated so as to maintain the physiological function of those organs. But this azathioprine is non-specific in its action. It will act on all the cells which are rapidly dividing. Now we wanted to produce a drug which will act only on the lymphocyte and it spares the other rapidly dividing cells. So that is why there was a fungus named Penicillium stoloniferum. And from this fungus, they isolated an agent which was called as mycophenolate mofetil. And when this mycophenolate mofetil was given, the liver metabolized this into mycophenolic acid. What this mycophenolic acid does is this mycophenolic acid goes and inhibits inosine monophosphate dehydrogenase. Now, this inosine monophosphate dehydrogenase is required for the production of GMP. Now, because this is inhibited, the GMP is not produced. GMP is a very important purine. Because there is no purine, the RNA and DNA cannot be synthesized. So that is why it arrests the cell in all the rapidly dividing cells. But what happens is most of the cells in the body, the other cells in the body, they have an alternate pathway where they can produce this GMP directly without depending upon the inosine monophosphate. Even this pathway is blocked, they have an alternate pathway which is also called as salvage pathway through which they can directly produce GMP and they don't need to depend upon the IMP dehydrogenase except lymphocytes. So in case of lymphocytes, this IMP dehydrogenase is the only pathway through which it can produce GMP. So that is why mycophenolate mofetil can act only on lymphocyte. It can act on all other cells, but its action is fruitful only in the lymphocytes because they do not have a salvage pathway. And in that sense, it is more specific than azathioprine, and that is why it has been replaced. It has replaced azathioprine in most of the conditions except in pregnancy. Right? In pregnancy, the agent of choice, the proliferative agent of choice is still azathioprine, except in pregnancy. In all other conditions, mycophenolate mofetil has replaced azathioprine. But because it acts only on the lymphocytes, its side effect is that it produces leukopenia. And one frustrating side effect of mycophenolate mofetil is that it causes diarrhea. So this is about antiproliferative agents. Now we'll move on to something called as calcineurin inhibitors. A microbiologist once isolated a soil sample on his vacation, and from this soil sample, he isolated a fungus, which was called as T. inflatum. Now, from this fungus, he isolated a cyclosporin A. Now, he actually wanted to produce an antibiotic from this fungus, but this did not have any antibiotic properties. But surprisingly, this had a immunosuppressive property. So now this cyclosporin A is used as a immunosuppressive agent. What happens is when you give this cyclosporin A, this will enter inside the cell, and in the cell, this cyclosporin A will combine with a protein that has affinity to this cyclosporin. So we call it as cyclophilin because it has affinity to cyclosporin A. And this will form a complex known as cyclosporin cyclophilin complex. Now this complex will go and bind to the calcineurin colmodulin complex. Now this calcineurin colmodulin complex is required for the activation of NFAT. Now NFAT is required for the production of interleukin 2. Right? So when you give this calcineurin, it goes inside, it binds to cyclophilin, forms a when you give the cyclosporin A, it binds to cyclophilin, forming a cyclosporin-cyclophilin complex that inhibits calcineurin colmodulin complex, which will inhibit NFAT and which eventually inhibits interleukin 2. So it reduces the production of interleukin 2, and hence it is used as a maintenance agent. But unlike steroid, it does not have any other effects. Its only effect is to reduce the interleukin 2. So if the rejection has already started, it means that there are lots of interleukin 2 already produced, and these are activating T cells. Now, further reduction in the production of interleukin 2 does not have much effect because already interleukin 2 is produced and enormous in number. So that is why these cannot be used as rescue agents. They can be used as maintenance agents only, because you need in rescue agent, you need to inhibit something that has not yet produced. But here, interleukin 2 is already produced and it is in large numbers, and inhibiting its production will not have much effect. That is why cyclosporine A was used as maintenance agent only. This is first problem with this. And the second problem with this drug is that initially when this cyclosporine A was given, this was water insoluble. Now, because it is water insoluble, and you know that most of the gut secretions are watery in nature, and it needed bile for it to get absorbed. But if there are disorders, like for example, you need to get a liver transplant and the patient has a problem with the hepatobiliary system where the production of bile is altered or reduced, in such cases, it could not be absorbed easily. So that is why they produced an emulsified form of cyclosporine A, which solved the problem. The third thing is when it is given with other agents. Right? So this cyclosporine A is one of the drugs which is metabolized by cytochrome P450 enzyme. Now, there are certain drugs which will induce this enzyme, and there are certain drugs which will inhibit this enzyme. So, for example, if you look at the inhibitors of cytochrome P450, there are grapefruit juice, erythromycin, calcium channel blockers, and ketoconazole. Now, these drugs will inhibit cytochrome P450. As a result, they will slow down the metabolism of this drug. So more drug is available and they increase the efficacy and the toxicity both of cyclosporine A. Right? Because they inhibit cytochrome P450, drug is not metabolized. It remains for longer time. So the efficacy is increased and its potency and toxicity both are again increased. But if there are certain drugs that induce this cytochrome P450, right? Know that it is phenobarbital, phenytoin, and rifampicin. Now, these drugs will induce cytochrome P450. They cause faster metabolism of the cyclosporine and they reduce its efficacy. So this is one problem. And the other problem is the most important problem perhaps is this cyclosporine A. It not only reduces the production of interleukin 2, it also increases the production of transforming growth factor beta. And most of the side effects of cyclosporine A are because of increase in the production of transforming growth factor beta. So what this does is it will go and it will act on the renal cells to produce endothelin. Now this endothelin is a powerful vasoconstrictor. It causes vasoconstriction of the renal blood vessels and it reduces the renal blood flow by about 30%. So it causes 30% reduction in the renal blood flow. This also acts to stimulate the renin-angiotensin-aldosterone system and contributes to renal hypertension. But most importantly, this transforming growth factor beta, it causes the fibrin deposition in the kidney, which will lead to the fibrosis. So if kidney transplant is done into this new kidney, it causes fibrin deposition, leads to fibrosis, and leads to what is called as chronic allograft nephropathy. Right? So these are all the effects on the kidney. It causes reduction in the renal blood flow by 30% by stimulating endothelin. It stimulates renin-angiotensin-aldosterone system and causes renal hypertension, and it causes fibrosis in a transplanted kidney, leading to chronic allograft nephropathy. So this is nephropathic effects, but this also causes neuropathic effects. So the patient can have paresthesias, severe headaches, confusion, somnolence, and tremors. And this cyclosporine also has cosmetic side effects. It can cause hypertrophy of the gum, gingival hypertrophy, and hypoplasia. Gingival hyperplasia can happen, and it causes hypertrichosis. There is increased amount of hair growth seen especially on face, arms, and back. So causes cosmetic side effects, and this is seen in about 50% of the patients where there's a hypertrichosis. So these are all the problems with the cyclosporine. So that is why to prevent these problems or to reduce these problems and to develop a more potent agent, they developed another calcineurin inhibitor, which is called as tacrolimus. Now, this tacrolimus is isolated from a bacteria, Streptomyces. So, it is from a Streptomyces species. This tacrolimus, it is actually a macrolide. When this tacrolimus is given, this tacrolimus will enter into the cell, and in the cell, instead of binding to cyclophilin, it binds to immunophilin. Right? So most of the times, this immunophilin is a FK binding protein. Right? It is a FK binding protein which will eventually inhibit NFAT, and it inhibits interleukin 2. But what is to be noted is, along with inhibiting interleukin 2, this also inhibits interferon gamma, and this is 100 times more potent than cyclosporine, right? So because it inhibits interferon gamma and 100 times more potent than cyclosporine, this can also be used as a rescue agent. Right? It is used as a maintenance agent, but because of its additional effects, it can also be used as a rescue agent. And this tacrolimus has become a cornerstone in the modern immunosuppression. So, in all the solid organ transplantations, tacrolimus has always been an invariable component. Almost 90% of the hepatic transplant patients will receive tacrolimus as a maintenance agent, and it can also be used as a rescue agent. Right? So, if you compare cyclosporin A and a tacrolimus. Now, this cyclosporin A is from a fungal source, which is T. inflatum, and tacrolimus is from a bacterial source of Streptomyces species. Cyclosporin binds to cyclophilin, while tacrolimus binds to immunophilin, which is a FK binding protein. Now, both of them will inhibit NFAT. This also inhibits NFAT, which eventually inhibits interleukin 2. This, along with inhibition of interleukin 2, it also inhibits the production of interferon gamma, and it is 100 times more potent. So, for this reason, this is used only as a maintenance agent. This can be used as a maintenance agent and a rescue agent. Now, this also upregulates the production of transforming growth factor beta, and tacrolimus also upregulates the transforming growth factor beta production. But the difference is tacrolimus has got less cosmetic side effects, right? But it has got more neurological side effects compared to that of a cyclosporin A. So when you compare this tacrolimus with cyclosporin in their side effect profile, it has got lesser cosmetic side effects but more neurological side effects. Now, if you remember, I told you that interleukin 2 comes and acts onto the interleukin 2 receptor, which is present on the T cell. And if the signal is given to this interleukin 2 receptor, it is responsibility of this receptor to transmit this signal to the nucleus. And one of the important intermediary in the transmission of this signal is a mTOR. And it is a complex, especially mTOR complex 1. Now, if we can produce a monoclonal antibody against this mTOR complex 1 receptor, we can prevent the activation of the T cell. So in the Pacific Oceans, there is an island which is called as Rapa Nui. From this island, they collected the soil, and from this soil, they collected this bacteria, Streptomyces hygroscopicus. From this, they isolated a macrolide, and because it is a macrolide from the Rapa island, they named it as rapamycin. And this rapamycin was later called as sirolimus. From this rapamycin, they developed another derivative which is called as everolimus. So sirolimus and everolimus are mTOR inhibitors. So what this mTOR is? So this is a rapamycin, and this is target of the rapamycin in the human body. So it is a mammalian target of rapamycin inhibitors. So this is the next class of drugs that we are discussing. Mammalian target of rapamycin inhibitors. So these are sirolimus and everolimus. Now, when the sirolimus and everolimus are given, they will enter inside the cell, and in the cell, this sirolimus and everolimus, just like the tacrolimus, because these are also macrolides, they will bind to the receptors, which are intracellular receptors, just like tacrolimus. They will also bind to immunophilin, which is FK binding protein. So once they bind to FK binding protein, unlike tacrolimus, they do not choose the pathway where they inhibit the interleukin 2 production. So what they do is they will inhibit this mTOR, right? So when interleukin 2 comes and binds to the T cell receptor, this interleukin 2 production is inhibited by tacrolimus. But here, when it comes and binds to the T cell, this activates the intracellular signal transduction pathway. And one of the important component is mTOR. This mTOR is inhibited by the sirolimus and tacrolimus. So they are mTOR inhibitors, especially the complex one of mTOR. Along with that, they also inhibit the signals which are produced by interleukin 4, 6, and platelet-derived growth factor, right? So also inhibit interleukin 4, 6, and platelet-derived growth factor signals. So you can use them as maintenance agent. Also, because they inhibit these signals, they are a part of drug-eluting stents. Right? So when it comes to uses of sirolimus and tacrolimus, you are using them in immunosuppression as maintenance agents, and they can be used as drug-eluting stents. Right? For example, if you put a coronary stent, because the stent is a foreign body, now the body can produce immune reaction against this stent and lead to the fibrosis in the stent and lead to stent stenosis, in-stent restenosis. So they are used as drug-eluting stents, where there is a slow release of sirolimus and everolimus, which will inhibit this instant stenosis. Also, they can be used in the treatment of lymphomas. The sirolimus is used in treatment of B cell lymphomas, and everolimus is particularly useful in Epstein-Barr virus induced lymphomas. These are all the uses of these mTOR inhibitors. And when it comes to side effects, these can cause hypertriglyceridemia and hypercholesterolemia. So much so that they need either discontinuation of the drug, or they need a drugs which will reduce this triglycerides and cholesterol in the form of statins, and they can also cause oral ulcers. This is about mTOR inhibitors. Now, there is something called as co-stimulation in the body, in the immune response. What happens is, whenever there is an antigen that is present, that enters into the body, now this antigen has to be presented to the T cell. Now, the cell that presents it is a antigen presenting cell. So when the antigen presenting cell presents this antigen to the T cell, what actually it means by presenting is it has to send two signals to the T cell. One signal is a major histocompatibility complex. Through the MHC, it sends the first signal. But it also needs to send a second signal. This signal is via CD8086 onto the CD28, right? So once it comes and binds to the T cell, it needs to send the first signal via the MHC, and the CD80 or 86 of the antigen presenting cell has to interact with the CD28 on the T cell and produce a second signal. Now, this second signal is called as co-stimulatory signal. Now, unless the T cell receives second signal, it will not recognize this antigen as a foreign antigen. It recognizes it as a self antigen, right? So if APC comes and binds and produces only MHC and second signal is not produced, now T cell will not recognize this as foreign antigen. It recognizes it as a self antigen, and thereby, even though there is an antigen present in the body and the antigen presenting cell has recognized it as a foreign antigen, the T cell is not ready to accept it as foreign antigen because the second signal is not given, so that it will not mount an immune response against this antigen. So, if we could develop an antibody which blocks this CD8086, it binds to the CD8086 and it prevents its interaction with the CD28, then we will be successful in making the T cell realize that it is not a foreign antigen, it is a self antigen. So that is why what they did is they took a CTLA4 protein and they combined it with the FC fragment of a immunoglobulin and they produced a fusion protein. A fusion protein was produced, and this fusion protein was from a FC fragment of a immunoglobulin. A part of the immunoglobulin was taken and a CTLA4 was taken, and they produced this fusion protein and they named it as abatacept. Later, a better molecule was produced, which is called as belatacept. Right? So abatacept and belatacept, when given, they will bind to the CD80 or 86 of APC, right, antigen presenting cell, and they inhibit the second signal, which is called as co-stimulatory signal. And in the absence of this second signal, the T cell will not recognize the antigen to be a foreign. It thinks it is a self antigen and will not mount the immune response against this. So that is why these are called as co-stimulation blockade drugs. So these are co-stimulated blockade drugs, abatacept and belatacept. But why did they choose CTLA4 only? This is because, as I told you, there is an antigen, and this is taken up by the antigen presenting cell, and that presents it to the T cell. Now, when both the signals are given, this T cell will mount a immune response against this antigen and causes destruction of this antigen. But once the antigen is destroyed, now the T cell has to be stopped. If not, it causes more damage to the host cells only. So there has to be down regulation of this T cell. Now this T cell on its surface expresses CTLA4. This CTLA4, when present, it will bind to the 8086. Right? So it binds to the 8086, and when it binds to 8086, it will inhibit the binding of 8086 to the 28 on the T cell. Right? So thereby it causes down regulation of T cell. Now, when we can block this 8086 with whatever drug that we wanted to block it, we could have only prevented the T cell activation. But if we choose CTLA4 to block it, one thing is it will come here, bind to 8086, and it will prevent the T cell activation. And those T cells, if they are already activated, this CTLA4 will inhibit the 28 and it causes the down regulation of T cells. Right? So already activated T cells will be down regulated and the new cells will be prevented from activating. That is why this CTLA4 was chosen. So this is about co-stimulation blockade. Now, till now, whatever we discussed was about the T cell mediated responses. Now there is B cell in the body. This B cell can get converted into a plasma cell. Now this plasma cell can produce antibodies which can mount a immune response against a antigen. Now that is called as antibody mediated rejection, right? So now we have drugs which can act on this antibody producing cells or on the antibodies and prevent this rejection, right? So we'll discuss about this AMR drugs. First would be a drug which can act on the B cell. This B cell, mature B cell, has a cell surface receptor CD20. So if we can produce a drug which will block this CD20, so that will block the action of the B cell, and that drug is a rituximab. Right? So cimab meaning it is a chimeric drug. So rituximab is a chimera which acts on CD20 and it blocks the B cell by inhibiting CD20. So that is why it was initially used in the treatment of lymphomas. Now, this can also be used in treatment of antibody-mediated rejection or to prevent the antibody-mediated rejection. And these plasma cells have a receptor which is called as CD38. And if we can produce a drug which blocks this CD38, that is a daratumumab. So daratumumab is a completely human monoclonal antibody which will block the CD38 and thereby inhibiting the plasma cells. Also in the plasma cells, there are proteosomes. Now these proteosomes are repair enzymes. Now if we can inhibit these proteosomes, then we have the inhibition of the plasma cells. So those drugs which inhibit this proteasome, they are called as zomib because they are zome inhibitors. So they are called as zomib. And the two drugs are bortezomib and carfilzomib. Right? So these are the drugs which act onto the plasma cells. Now B cell has got converted into the plasma cell. Plasma cell has already produced antibodies. Now, if we can produce antibodies against these antibodies, now they are called as IVIG. So these are intravenous immunoglobulins, which are the antibodies against the antibodies. So they are used to treat antibody or to prevent antibody mediated rejection. They are also used in Guillain-Barré syndrome, in idiopathic thrombocytopenic purpura, and in myasthenia gravis crisis. So these are all the drugs which can be used to prevent antibody-mediated rejection. Rituximab, which is a CD20 inhibitor, daratumumab, which is CD38 inhibitor on plasma cell, and proteasome inhibitors, bortezomib and carfilzomib, and intravenous immunoglobulins, which will block the antibodies. And then in the last class of these drugs, as I told you, once the body has started immune response, it utilizes various cells to destroy this graft. And the ultimate step just before the destruction of the graft would be to activate the complement. Right? So there are various cells here. T cells are there, B cells are there, monocytes, macrophages are there, pro-inflammatory cytokines, interleukin 1, 2, 3, 4, 5, 6, tumor necrosis factor alpha, all of them are there. But ultimately, they culminate in activation of complement. And this complement will produce membrane attack complex and that destroys the graft. So if we can block this, even if by some or the other reason it escapes here, if we can produce a substance that can block this complement, we will be successful in saving the graft. And one such important component of this graft is C5. Right? Of this component complement system is C5. And there is a drug which inhibits this C5 that is called as eculizumab. So it is a humanized monoclonal antibody which inhibits the C5. So it inhibits the membrane attack complex and saves the graft. So these are all the various drugs which are used for maintenance phases. So if I have to list it, so it would be a steroid. Oral steroid is prednisone and IV steroid is methylprednisone. It would be an anti-proliferative agent, which is azathioprine or mycophenolate mofetil, or it could be a calcineurin inhibitor, which is cyclosporin A, or it could be a tacrolimus. It could be a mTOR inhibitor, which is sirolimus or everolimus, or it could be a co-stimulation blockade, which is abatacept and belatacept. It could be antibody-mediated rejection inhibitor on the B cell. Acting would be a rituximab on the plasma cell. It could be a daratumumab or a proteasome inhibitor like bortezomib and carfilzomib, or it could be IVIG. And finally, it could be a complement inhibitor, which is eculizumab. Right? So these are all the various drugs with their actions and side effect profile that can be used in maintenance space. Now there are certain newer drugs which are called as novel agents. They are successful in studies, but they are not yet been a part of standard regimen. So these three drugs would be fingolimod or tofacitinib or a co-stimulation blockade. Again, so just like abatacept and belatacept, which block 80-86 interaction with 28, here you have a blockage of CD40 and 154. So there are many drugs which are under trial to block this CD40 and 154. Now, as I said, interleukin acts onto this interleukin receptor, which is present on the T cell, and it will produce the signal transduction pathway. And one of the signal transduction pathways is a JAK-STAT mechanism. And there is a protein of this JAK-STAT mechanism, which is called as JAK3. Now, this JAK3 is inhibited by tofacitinib, right? So, tofacitinib is a inhibitor of the JAK3, which will block the signal of an interleukin to tell the T cell that it needs to get activated, and thereby it inhibits the activation of the T cells and proliferation of T cells. So that is the mechanism of action of tofacitinib, where it inhibits JAK3 protein. Now, what fingolimod does is, so normally whenever the lymphocytes are produced, these lymphocytes will be circulating in the blood, and some of them will be stored in the lymph node. So in the lymph node, there is a lymphocyte which is present in the lymph node. It is sequestered in the lymph node. And on this surface, there is a cell surface protein which is called as SPR, which is a cell surface protein out of many proteins which are present on this lymphocyte. So when, for example, you think there is a new kidney which is transplanted into this patient, now the immune system gets activated, and this immune system mounts an immune response to this kidney. So whatever the lymphocytes are present in the blood, they are called to this site where the kidney is transplanted, and these lymphocytes will start producing the immune response against this kidney. But that is not sufficient. Now, whatever the lymphocytes are resting in the lymph node, they want to get these lymphocytes out of the lymph node into the blood, and then they move to the kidney and they start attacking the kidney. For that, the immune system has to send a signal. Now, this signal, when it reaches the lymph node, this signal is taken up by the SPR protein, which is present on the cell surface receptor. This tells the lymph node to come out of the, lymphocyte to come out of the lymph node, enter into the blood, and go to the kidney and attack it. So when you give a fingolimod, what it does is, this fingolimod gets converted into active moiety, and this active substance will go and internalize this receptor. Right? So if this is a lymphocyte, it makes the cell surface receptor become internal. So even when there is a signal, this signal is not sensed by the T lymphocyte, and this lymphocyte will not come out of the lymph node. It remains in the lymph node. So if there is a lot of immune response going on outside in the kidney, this lymphocyte, which is sequestered in the lymph node, has no idea about it because it cannot sense the signal, and it remains in the lymph node and will not participate in the lymphocyte action against the kidney. So it will not participate in the immune response. So that is the action of the fingolimod. So these three are the novel agents which are still under trials. They are proven to be effective, but they have not yet been included in the standard regimes. So this is in brief about immunosuppression in transplant.